Hey, I'm doing this video of allergic rhinitis for review of primary care nurse practitioners to help in their clinical practice. Allergic rhinitis is actually an easy and simple diagnosis to make in clinical setting, but I made it a detailed PowerPoint for nurse practitioner students. Regarding me, I'm GV. I was an RN for 18 years, pulmonary nurse practitioner for 3 years, and primary care nurse practitioner for 1 year, and currently working as an autonomous nurse practitioner in Right Focus Healthcare LLC. Allergic rhinitis is defined as inflammation of mucous membrane of nose, usually accompanied by edema of nasal mucosa and a nasal discharge. It can be allergic or non-allergic. Historically, it was thought to be a disease of nasal airway alone, but later series found out it's a component of systemic allergic response with other associated conditions such as asthma and atopic dermatitis. I have done review videos for asthma, rhinosinusitis. I recommend viewers to watch those to know the difference between each diagnosis. Regarding epidemiology, it affects 1 in 6 individuals and is associated with significant morbidity and loss of productivity and healthcare cost. Etiology of allergic rhinitis. The most common one is seasonal, which is due to, as seen in the picture, inhalant pollen allergens. The next cause is perennial, which caused by, as you see in the picture, house dust mites, smoke, mildew, animal dander, and rarely food allergies. What is the difference from non-allergic rhinitis? The pathogenesis is by Ig-mediated inflammatory response, which we will discuss later. A word about non-allergic rhinitis. Number 1, gustatory rhinitis, due to the cholinergic reflex triggered by drinking alcohol or from eating in diseases like GERD. Number 2, occupational rhinitis, due to airborne substances like chemicals or dust in workplace. It's good to know that when it happens in a workplace, it's not classified in allergic rhinitis. Number 3, drug-induced rhinitis, due to the intake of ACE inhibitors, aspirin, NSAIDs, rebound rhinitis, or otherwise called rhinitis medicamentosa, due to the overuse of topical decongestants like Afrin. I have discussed that in other videos. Hormonal rhinitis, it occurs in pregnancy or it's related to menstrual cycle. Number 5, chronic lung diseases like in sarcoidosis. Number 6, in case of infections like in chronic rhinosinusitis, in anatomic problems like nasal polyp, deviated nasal septum, or trauma, or in emotional stress. Clinical features and pathophysiology of allergic rhinitis. What are the symptoms patient present with an allergic rhinitis? The onset of the allergic rhinitis is most common in ages 10 to 20. As you seen in picture, red, itchy, watery eyes. Number 2, sneezing, nasal congestion, runny nose, or clear nasal discharge. Do not forget, in addition to these nasal symptoms, patient with allergic rhinitis may also present with associated conditions, allergic conjunctivitis or sinusitis. What is the difference with the sinusitis? In sinusitis, there will be purulent discharge. In itchy or sore throat, postnasal drip or cough. Remember, chronic nasal congestion and postnasal drips are more findings in chronic allergies and allergic rhinitis. Next, pathophysiology. The allergic response is classified into early and late phase. In the early phase, initial response within the 5 to 15 minutes of exposure to an antigen, resulting in degranulation of mast cells. This release new mediators, including histamines, which causes sneezing and rhinorrhea, and leukotrienes and prostaglandins, which causes nasal congestion. So that is why antihistamines and leukotriene antagonists are effective in allergic rhinitis. Next is late phase. 5 to 6 hours after the original reaction, in person with severe disease, there is a production of interleukin 4 and interleukin 13 from mast cells. So these patients, even if even hyperreactive to normal stimuli such as tobacco smoke or cold air, and that causes symptoms of sneezing and rhinorrhea and nasal pruritus, that's how you know it's chronic disease. And also, study shows that the risk factors of allergic rhinitis are family history of allergic rhinitis or asthma or atopy, male sex, or heavy exposure of cigarette smoking in the first year of life. How to diagnose allergic rhinitis? First, history, assess the onset, duration, and progression of symptoms. We already discussed the symptoms. Assess the relationship of symptoms to season, place, time, and activity. Then, family history of asthma, atopy, history of allergies, medication history, comorbid conditions like sinusitis, color and consistency of nasal discharge. Then ask about mouth breathing and need of constant clearing the throat, snoring during sleep. Ask about offending allergens, seasonal, any triggers like a spicy food, changes in temperature. And then drug abuse, ask them about use of nasal sprays, assess the quality of the life. Next is physical examination. Physical examination on otoscope examination, findings are pale, boggy nasal mucosa with clear thin secretions, enlarged nasal turbinates. On throat exams, enlarged tonsils or adenoids. Next are, like you can see, 3 pictures in the slide. It's not a requirement or needed for diagnosis in the clinical settings for allergic rhinitis. This is for nurse practitioner students for their knowledge. Nasal salute, the first picture, you can see a scar on the nose. It's a nasal salute is transverse nasal crease due to the chronic wiping of the nose. Second picture, allergic shiners. Dark discoloration beneath both eyes. Third picture, Denny Morgan lines or Denny's lines, extra wrinkles below lower eyelids. Another point, if rhinitis is unilateral, suspect foreign body or anatomic problem. Also assess breath sounds for any concurrent asthma. Also assess skin for any rashes and assess lymph nodes for any lymphadenopathy. Management of allergic rhinitis. Number 1, effective treatment of respiratory inflammation. So, decrease incidence and worsening of comorbidities like asthma and other diseases like otitis media and sinusitis. Number 2, patient education in allergen avoidance. We will talk that in patient education section. Number 3, medication. You can see a comparison table. There's eight type of medications and 5 symptoms: pruritus, rhinorrhea, nasal congestion, sneezing, and eye symptoms. If you know this table and advantages and disadvantages of each class of medication, it's easier to choose medication. This table shows which medications work for each symptoms. Look at the table. You can see that the more pluses, the rhinorrhea, nasal congestion, sneezing has three pluses in intranasal corticosteroids, and pruritus and eye symptoms 2 pluses. So that means they are the most effective medication which treated 5 symptoms. So thereby it's the first line intranasal corticosteroids are the first line treatment and the most effective treatment. Advantages: it controls all symptoms, few side effects, and control underlying inflammatory response. Disadvantages: patient may not see the effects until 2 weeks. Adverse effects are epistaxis, nasal irritation, or bleeding. But we have always prescribed patients this medication but have not seen that side effect, and I always advise patient to use concurrently nasal saline spray, especially when there is nasal congestion. Number 2, you can see that the next one in the table, which has more plus, is antihistamines, which is oral and nasal. Nasal antihistamines is not relieving eye symptoms but relieve all the other symptoms. Oral antihistamines almost relieve every symptoms but minimal control of nasal congestion. Then next section is the leukotriene antagonist, which only control 3 symptoms: rhinorrhea, nasal congestion, and eye symptoms. No relief of pruritus or sneezing. Then we see intranasal anticholinergic that only relieves rhinorrhea. Why this table is important? Because suppose a patient come with all other symptoms except rhinorrhea, and the intranasal anticholinergic only relieves rhinorrhea is prescribed, patient is going to come back with all the other symptoms because other symptoms are not controlled by this medication. Then you can see decongestants, oral and intranasal, which is intranasal has 4 pluses which relieve nasal congestion more than oral decongestants. Medications in detail. As you see in the table, the first one, intranasal corticosteroids. Examples are fluticasone or Flonase, 1 to 2 spray in each nostril daily. Mometasone, 2 spray in each nostril daily. I have already discussed in the last slide the advantages and disadvantages. This is the most effective treatment and the first line treatment. Number 2, remember the slide in the last slide, the more effective is antihistamine, the next to the intranasal corticosteroids. Out of that, the antihistamines, the first generation antihistamines, I haven't included in the table because of their side effects. The anticholinergic effect like dry mouth, urinary retention and constipation, and it can cause drowsiness, and we have to be very cautious in elderly glaucoma, and it may worsen asthma symptoms. Example are Benadryl and Atarax. The second generation antihistamines, examples are Sirtec 5 mg daily, Clarinex 5 mg daily, Fexofenadine 60 mg BID, Loratadine 10 mg daily. Advantages: fewer side effects, and it treats, as you remember in the last slide, it treats all symptoms, 5 symptoms. And disadvantages: it has only minimal relief of congestion, but all the other symptoms are better controlled and do not control an inflammatory response. Next is in the table is the intranasal antihistamines. The advantages are good safety profile, effective in reducing symptoms, more effective in relieving nasal obstruction than oral antihistamines. Disadvantage: cause a slight sedation, a bitter taste, less effective than nasal steroids. Examples are, this also IV uses in the clinical settings more often, as elastin 0.15%, 1 to 2 actuation in each nostril BID. Next one is intranasal anticholinergic agents, which helps only in one symptoms, as remember in the table, rhinorrhea. The popular one is ipratropium. It's discontinued in US per Hippocrates. Number 5, it's oral anti-leukotrienes or oral leukotriene antagonist. The examples are Singular or Montelukast 5 mg daily. The advantages: there is fewer side effect. Disadvantages is expensive and less effective because remember the last slide, it's only control 3 symptoms and it's minimal control: rhinorrhea, nasal congestion and eye symptoms, but no relief for sneezing or pruritus. And but I have to say the Singular has a black box warning recently, and Montelukast, the generic, is not expensive that much as the branded one, Singular. Next one is the decongestants. Decongestants are of 2 types: intranasal and oral decongestants. The advantages: it relieves nasal congestion, especially the intranasal has 4 plus in the slide, so that means very effective for nasal congestion. The disadvantages are that we have to be very cautious in older adults and patients with the heart disease, hypertension, because of its vasoconstriction effect, and with the history of patient, very cautious in young children, history of heart disease, cardiovascular disease, and not recommended more than 3 days for the intranasal corticosteroids, or the oral decongestant not more than a week. The intranasal examples are Mucinex 2 to 3 sprays, Q12 hour. Do not use more than 3 days. Oral decongestants examples are pseudoephedrine 60 milligram PO Q6 hour PRN. It relieves the congestion, but there is side effect of palpitations. So next is combination. So these oral decongestants can be combined with the oral antihistamines. Remember in the table, the oral antihistamines relieves all the symptoms except good control of all the symptoms except a minimal control of nasal congestion. So it can be combined with oral antihistamines for effectiveness. Allegra D24 hour, it's a combination of fexofenadine 180 plus pseudoephedrine 240 once daily. Allegra D24 12 hour is fexofenadine 60 plus pseudoephedrine 120 Q12 hour PRN. Then the adjunctive therapy is saline nasal spray is can liquefy the mucus and prevent from the mucus from crusting. Regarding follow up the patients after prescription of medications in 2 to 3 weeks. Referral, usually patients of allergic rhinitis can be managed by primary care physicians or practitioners, but referral to allergist or immunologist is indicated in case of poor symptom control and adverse reaction to medications, which we already discussed. Nasal polyp, if it is bilateral, it is benign, but if it is unilateral, there is a concern of malignancy. And in comorbid conditions, asthma, and then there is reduced quality of life, and in patient is in need of allergen immunotherapy. According to American Academy of Otolaryngology guidelines, allergy testing should be reserved for patients who are unresponsive to empiric treatment or require the identification of a specific allergen to the target therapy. Consider allergen immunotherapy for patient who has evidence of specific IgE antibodies to clinically relevant allergens. The advantages of allergen immunotherapy is that it's reduce the risk of development of asthma, and also it's effective for common allergens like pollen, animal dander, and desmites. That's a rare case which may have to do it, but if it is again the allergen is identifiable and it's for a long time and all the indications that I discussed. And then there is complications, sinusitis. If it is greater than 3 months, it's a chronic rhinosinusitis, nasal polyps, which I already discussed, and eustachian tube dysfunction, which lead to ear problems, otalgia, ear fullness, and otitis media with effusion. Next is prevention and patient education. Out of the treatment that we discussed, we see that four of them are nasal applications. Treatment will be effective if patients know the correct technique. As you see in the picture, prime the device and a clear nose or blow nose before administration of medication. As you see in the picture, second picture, keep head upright and tilted slightly forward. Squeeze the bottle as you slowly breathe through the nose. Spray medication away from the septum, which is the third picture, which pointing towards same side eye or ear. Not towards the septum or not towards the upwards. Wait at least 1 minute before second spray in each nostril. If possible, avoid sneezing or blowing nose for 5 to 10 minutes after spraying. Cleanse medicine canister device after each use. Next is patient education regarding environmental control. The goal is that the home is free from any kind of allergens. Advise them to do vacuum weekly, and the equipment should be cleaned regularly, or advise damp mopping, dust furniture with damp cloth, wash sheets and blankets in hot water weekly, encase mattress and pillow in allergen impermeable cover, remove carpets from bedroom, avoid any rubber mattress, keep windows and doors closed to reduce the influx of mold and pollen, have AC unit checked or cleaned, then eliminate or restrict exposure to pets. If pets remains in the home, isolate in a room or wash pets weekly. To control pests, use traps or bait. Do not leave food or garbage exposed. Wear mask when longs and also wear long sleeved shirt when gardening. Hey, I'm concluding my video of allergic rhinitis. Thank you for watching. I hope it was helpful for primary care nurse practitioners and nurse practitioner students. Thank you again.